you very much indeed. And with that, we move on to the question and answer session.
Before starting, thank you, Simon, for brilliant summary. You have clarified a lot of points. So we will start with the first question from the audience. Mark, for you, Dr. Jimenez, do you have any experience in the use of NIRS for monitoring spinal cord ischemia in thoracic aortic aneurysm surgery, open or endovascular? Where do you place the sensors? What do you consider significant in terms of a drop in saturation? Thanks from the person who has asked.
I mean, I think that we can talk all the lectures on what is our current practice and what the hospitals do, but I think that most important than that is what do we know from the evidence. And as I said in my lecture, the evidence in thoracoabdominal aneurysms is really limited. What we have more in NIRS, in vascular, is in carotid endarterectomy. If we need to extrapolate from carotid endarterectomy to other types of surgeries, I would say 20% of drop. Okay, but as I said, we don't have good studies in humans. Okay, as you've said, Kavita's presentations, she has reported a few studies in animals, but in humans is limited. Now, you're interested in knowing what we do in our hospital. In our hospital, we use NIRS, okay? We put it in lumbar and thoracic, but we also use Dr. Tercero advice for guiding us towards ischemia of the spinal cord. I don't know whether the rest of the panel would like to add anything or...
Dr. Escriva, do you have any opinion? Oh, Maximilian, please.
Yeah, so I work with Christian Etz, and so he's the one who published all this stuff. And so all of the studies were done here in Leipzig with the NIRS. So that's what we used. And actually, I know in human, there's only one study that is the study from Van Aspern, that was one of the surgeons who just moved to Bremen, and that demonstrated surprisingly that when they clamp the thoracic aorta, the lumbar NIRS always drops. If it drops more than 10% in the first 10 minutes, that's the only sign that correlates with actually spinal cord ischemia. So for us, it's and it's something that's completely new for me, and I would like to, like, outside of this panel, so discuss with you guys from Barcelona, because I worked in Toronto, in Canada, where we so it's funny. When we started with thoracoabdominals in Toronto, we went to Texas Heart Institute to see how the guys down there do it with Joe Coselli, which is like sort of the surgeon for thoracoabdominal aneurysm. They use no monitoring, zero, nothing. Then in Toronto, we started doing it with MEP and SSCP, as you do it in Barcelona. And then here in Leipzig, we do it only with NIRS. So it would be very interesting for me to, and I'm not sure if anybody ever correlated. You have like a big potential for like to write it up if you have the data. To correlate NIRS and MEP and SSCP. So for us, what's important is actually to look at the difference between thoracic and lumbar. I mean, as you know, unfortunately, my experience is, yeah, we can tell the surgeons, we can try to do our best. We talk to the perfusionist, we try to perfuse the distal aorta at a higher pressure, and sometimes, despite all our effort, we still cannot bring the lumbar potential high. But what I think I mean, my experience here is the difference between thoracic and lumbar. More than 10% for us is actually a trigger to do something.
Yeah, just from our perspective, we're using both. We use MEPs and NERS as well, but we are relying on the MEPs. and the NARS is additional information. And I think an important point is the surgical technique that is used, as you said, Max. So you have techniques with a left bypass, you have techniques with a total bypass, techniques where all arteries will be undergo perfusion during the procedure. That's a very important difference, and I think it's important the local practice in the hospital which technique best fits. I have to admit the data on NRS for thoracoabdominal surgery is very, very limited.
Many thanks for that. I think in the course of that conversation, we have identified one of our alarm or alert limits, the 10% difference that Nash referred to, which is interesting. Another question for Mark. Does it make sense to use local frontal measurements for tissue oxygenation to exclude the occurrence of focal ischemia? Would it in possibly a more distant cerebral area? So I think it refers back to the comment you made about the focus on frontal monitoring, and if there's anything we can do about that.
Thank you, Simon, for the question. I mean, as I said in my presentation, if you put the sensor, you're going to analyze the tissue oxygenation around 2-3 centimeters. So, I mean, unless you have frontal ischemia, you're not going to detect. If you put, I mean, it's going to be just in the area where the sensor is located, not remotely.
Thank you very much. Pucci.
Yes, a question for Dr. Ana Tercero. Ana, neuromuscular blocking agents do not block nerve synaptic transmission. They only interfere with neuromuscular transmission. Since MIPS and SIPs pick up nerve potentials and not electromyogram, so why should we not use neuromuscular blocking agents?
So thank you, Pucci, for reading the question. So we don't have any problem to use neuromuscular blocking with SSCPs because, as you said, we will not see the twitch of the muscle, but we can record and average the potentials, the waves. And also it will be nicer than without neuromuscular blocking because there will be not interference of that. But for MEPs, it affects the neuromuscular transmission, so there is not a muscle contraction, and that's what we are recording, the bucket potentials that is elicited from the motor barrier and arrives to the muscle. So we don't pick up nerve potentials, we pick up muscle bucket potentials. So that's why neuromuscular blocking are not useful or can interfere in the responses of motor bucket potentials. I don't know if you have answer.
Thank you very much for that, Anna. Jan, a question about the pressure of the CSF pressure monitoring and drainage. About where we look after these patients.
Depends on when the catheter has been placed. So if the catheter has been placed a day prior to surgery, we have to take the patient to a monitored unit or a unit with monitoring, or IMC or something like that. That doesn't need to be an intensive care, but a unit where we can look after the patient. And if the catheter is placed on a day of the procedure, which happens, I think, in 80% of the cases, the patient will be taken to a monitor unit as well in an open procedure to the ICU, of course, and after an endovascular procedure on the we call it PECU, this post-anesthesia care unit, where the patient will stay for at least one night until the catheter has been removed.
So this is as much about the skill of the staff in the unit and making sure you've got the right people there.
Yeah, the main reason is, of course, that the patient may develop a spinal or epidural hematoma, which has to be monitored, and this is also medical legal important that the patient has been monitored after placement of the catheter. There's a lot of discussion about that, but you also have to admit that the people on the ward need to be feeling comfortable with the situation. And if you have a ward with 35 beds and only 2 nurses, that's not adequate for such a risky procedure. Let's talk it this way. So the patient in our hospital, the patient goes to an intermediate care unit.
I can see the medical legal challenge in this high risk situation. To some extent, it's a no-win situation, but we do the best we can. Thank you very much, Pucci.
Thank you, Jan. We do the same in our hospital. We put the patient in an intermediate intensive care unit. Now, another question to Mark, Dr. Jimenez. Please, I would like to know your insight on NIRS use for predicting AKI, acute kidney injury.
I mean, just do adults. I know that all the evidence from NIRS trying to prevent AKI comes from pediatric world. I think that is because of an anatomical reason. I mean, if you put the sensor in a 120 kilos patient, probably you're not going to measure regional oxygenation, but other things, and the kidney is far away. I think that, I mean, it would be nice to look at it, to be honest, but I mean, the difficult thing on that is that you need to make sure that you have the kidneys there and deep enough to detect them. Another important thing about AKI in vascular surgery is that it's not only due to ischemia. I mean, although, I mean, of course, it is ischemia and embolic events can play a role, but it's also because of the contrast. It's also because an NSAID. It's because of also metabolic reasons that you will difficult see with NIRS. But I think that it's an interesting point, and it may be good to look at it in the future.
Thank you very much for that, Mark. A question for both you and Anna about carotid surgery. How can NIRS monitoring during carotid surgery be used to inform the decision to place a shunt? So I don't know which of you wants to go. Anna, do you want to go first on that?
So maybe the question is more for Mark than for me, for Dr. Jimenez, because he's the expert in NIRS. I don't know if you want to answer better than me.
I mean, what is said, it's 20%. You should, I mean, between 20 and 10% is where you should advise surgeon to insert a shunt. That's the academic answer. The real life answer is that it depends on what you really do. There are centers that they rely more on the stamp pressure and they don't trust so much the NIRS values. There are centers that they rely more on NIRS values and not so much on stem pressure. And it is also the point on all the iatrogenic that you could cause with inserting a shunt. So, I mean, if you put shunts in old patients, you're going to have problems because you will have some distal embolization of some debris and some material. So it's not like a free thing that you're going to do to a patient. So, I mean, what I would say is that, I mean, before advising the surgeon, you should really be sure that you're having a real drop, and it's not because of your interference or because of problems with technical problems with the devices. You need to study the patient before, and you need to know what's the contralateral carotid artery doing, and try to predict whether you will have problems or not with that. If you have contralateral huge stenosis, then if you see like 12, 14% of decrease, then you will start convincing the surgeon, because we all know how surgeons are, and they will take like 5-10 minutes to get convinced that you need some help to optimize the brain. So that would be my question.
Thank you very much indeed for that. I know what you mean. Only 5 to 10 minutes to be convinced. Pucci, over to you.
Excuse me, I was muted. Thank you for your answer, Mark. And one question for Professor Schreiber. One member of the audience asked, I would really like to know your opinion on hemoglobin target values during endovascular aortic repair in relation to the prevention of spinal cord ischemia. What is your target? Is there evidence for prophylactic transfusion? Should we really do prophylactic transfusion to high hemoglobin levels? Please.
As far as I know, there's no evidence for prophylactic transfusion, and I wouldn't do that. What we do is in our pre-anesthetic clinic that we try to identify anemic patients and try to treat anemia preoperatively, which is, of course, if you have a screening period of a couple of weeks before, which is feasible. We don't really have a critical hematocrit or critical hemoglobin. So we are using classic or standard transfusion triggers. That's not for patients on the bypass. We have a different protocol for that. And of course, it depends on the comorbidities of the patient. So if the patient has a higher risk for anemia, or to have a higher morbidity or because of anemia, and he has cardiovascular disease, for example, or kidney renal failure, then the transfusion trigger will be higher, but we don't do prophylactic transfusion in T-bars.
Thank you very much.
It's sufficient.
Thank you very much.
I think a question for you all, which I think is one that taxes us all from time to time. I know for Tujan, but I think we all have a view on this. Do you put CSF drainage in a patient who is anticoagulated? And I think that plays exactly into the. How about the post-operative period, though, where you may be asked to where you may be asked to therapeutically drain somebody who's probably still got a coagulopathy?
Yeah, that's a quite difficult question. So prophylactically, we wouldn't do that. We have we are following the ASRA guidelines, which are for nerve blocks, central nerve blocks. So we try to avoid patients with clopidogrel. Patients with NOACs have to stop NOACs for at least 3 days. Clopidogrel is 7 days. Aspirin is accepted in low dose, but we don't do this on the running anticoagulation. Indeed, a therapeutic CSF drain postoperatively, it really depends. So if you have a patient, you have to make a calculation how hard does the patient need this drain or not, and then the drain will be placed even if the patient has prophylactic anticoagulation. But routinely in the elective setting preoperatively, we don't do that. We have discussions with our surgeons about clopidogrel because a lot of vascular patients in the meantime have clopidogrel instead of aspirin. But we are following the guidelines from the societies of regional anesthesia.
So you wouldn't place a prophylactic drain on clopidogrel?
No, I wouldn't. I know there are case series because the evidence is very low, and there is a case series published a couple of years ago where a group, I think from the US, did that. With no impact on spinal cord injuries or epidural hematomas. But I think the evidence is, I think it's not safe enough.
Still, yes, you say, it feels like a brave thing to do.
Yes,
over to you.
Yes, a question for Mark. Thank you, Jan, for your answer. Is there anyone, Mark, who used MESPER, jugular venous saturation catheter? And if you do use, how was this result?
Thank you. I mean, I gather that it's a question for the whole panel. No? I mean, whether
Yes.
we are using this technology.
I suppose.
We don't. We in theater for carotid endarterectomy, or to try to know how the regional oxygenation of our brain, we don't use. We used to use it in neurocritical patients in ICU, but in a complete different setting. So that's, I don't know the rest of the people what the current practice is.
We never use it. We are working in the same hospital, but I am older than Mark and never have used it.
We also have no experience with that.
Thank you very much.
Mine is running a study on this at the moment, but I don't know anything about the results. It's very preliminary.
Many thanks. I'm sorry to cut across you. So the last question, because I'm told our time is coming rapidly to an end. Question for Mark, though you all may have views on this and thoughts on this. How do EEG and NIRS correlate? One measures surface cortical oxygen. Do NIRS and EEG changes track each other or not?
I mean, I'm excited about all the interest in NIRS because, I mean, it means that maybe we will establish and develop research networking between centers. So I think it's a very good point. I have explained that in the presentation. I mean, there is correlation in carotid endarterectomy between Doppler and NIRS, and they correlated well. And there is also correlation between NIRS and the stamp pressure. So, I mean, it correlates well with the rest of neurophysiological monitoring ways.
Many thanks for that. Let me just then thank all of the speakers for an excellent question and answer session. All the questions will be posted on the EACTA website and will be available a little time after and of course the responses will be posted on the EACTA website and will be available a little time after this webinar. And it's now my pleasure to hand over to Pucci to wrap up this webinar for us.
Thank you, Simon. So, dear colleagues, I hope you have enjoyed it with the webinar and thank you for attending it. Now, before finishing, it's a pleasure for me to introduce Professor Mohamed Al-Tahar from Mansour University in Egypt. He is the chair of the education subcon of the EACTA-IC. And really, he is the conductor and the soul of all the webinars of the EACTA-IC. Please, thank you, Mohamed. And
thanks so much, Dr. Matute, for your kind efforts and support to make this webinar. And the special thanks to Dr. Simon Howell to moderate the webinar with you, as well as all esteemed speakers, which we are honored to be on panel today. On behalf of Professor Patrick Waters, the chair president of EACTA and board of directors, I thank all delegates to coming this evening to attend the EACTA webinar. And to all esteemed speakers, special thanks to the organizing association management company from AIM and the provider of webinar from Multi-Learning. And it is accredited by UEMS to provide 2 credit points. You have to complete the evaluation form, which you will find it immediately after closing the webinar on the landing page, which you are logged into the webinar on it. And I am delighted to announce about the upcoming events. The first of them, it will be ECHO course. It will be between 11 to 12 and within 32 days, between 11 to 14 June. And then we have a third episode of seminars from Bad Oeynhausen from Germany on July, and we have a webinar and from ICU subcommittee about management of patient on ER deaths and VV ECMO. It will be in September. So thank you very much for joining this webinar, and have a lovely evening. Bye-bye.